Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 24 of the OBGYN podcast. Today is the Journal Club for September 2017, and before I get into that today, I just want to mark this little occasion. This is the one-year-ish anniversary of the podcast, and I'm just very pleased with how it's going. We have over 22,000 downloads since we started, and that's in 75 countries in all 50 of the United States. So really, we are growing into an international group here. And I couldn't be more pleased with all of you who make this something that we do on a weekly basis, or at least a couple weekly basis. And for the people who join the Slack, and we talk about things from all over the world about how we do things differently and connect, and just listen to some new ideas and new ways of doing things. So thank you all. I'm excited that we got to this 1 year mark, and I'm excited for the next 5 or 10 years. So to help me celebrate this 1 year anniversary of our Journal Club, I have Dr. Sarah Kim back from Stony Brook. Welcome back, Sarah.
Glad to be back. How's everyone?
Today, I think we have a great paper. I'm very excited about this one. All right, this is from the Gray Journal, AJOG in August. It is entitled Postplacental Intrauterine Device Expulsion by 12 Weeks, a prospective cohort study. And this is by Lisa Goldwaith et al. From the University of Colorado and Denver Health Medical Center. I chose this for a couple of reasons. One is that this is rapidly becoming a big issue in OBGYN. We already know that when women leave the hospital, if they don't have contraception, the odds of them getting contraception diminish rapidly. If they don't have a plan, I should say. In fact, we did a study at Stony Brook a few years ago, and the women who were undecided about their contraceptive plan when they left were much less likely to end up using any form of contraception. So this is huge. I don't know. I know we started doing this at Stony Brook a little bit, although I haven't participated in it. So I'm interested to hear what your thoughts are, Dr. Kim.
Yeah. So even at Stony Brook, I think when I first came here as an intern, we really weren't doing this. I think probably starting my latter half of intern year into second year, we were doing this a little bit more often, and it's an excellent option. Especially, I think a lot of times we talk about and discuss this in the office. Especially for like the younger population who may not, and who are maybe a little bit high risk of being lost to follow-up. And a lot of them, people who come in already with like 2 or 3 children, they find this a really great option because they're like, okay, when I deliver, I already have contraception plan, and I don't have to worry about having to follow up continuously to have a plan in place. So I definitely think that, especially in a little bit more the younger population, this is a very popular option.
Yeah. And the other thing in different states, and obviously 75 countries, we all differ a little bit in our healthcare system. But at least in New York State, where we both practice, there is a large contingent of women who only have access to healthcare when they're pregnant. And these are mostly our undocumented women. We have a lot of Central Americans who move here, and they work on various places out here in Long Island. But they only have access to healthcare for about 6 weeks to 12 weeks after they deliver, and that's it. And they may not have it again until they get pregnant again. And so to not only offer them contraception, but also offer them something that they don't have to think about for many years,
right?
And just works for them, that's huge. And so I really think, at least especially in that population where once they're gone from the healthcare system, they don't come back until they're pregnant, it's really a big opportunity to meaningfully impact that woman in her family's life.
Mm-hmm. Agreed. I've definitely done it on patients where, for various reasons, they might not necessarily be, for instance, a candidate for tubal ligation, postpartum. I think this is also a great option for those patients who may potentially lose their health care after they deliver.
Yeah. So just to dive into their introduction a little bit, I think it's well done. They really kind of state their issue. I think they spend a little too much time talking about the IUDs. I would have wished they'd talk more about what I was just saying about why doing it immediately postpartum is better than doing it at 6 weeks or whenever. But in any case, they make the case that IUDs, as we all know, are a very good form of contraception, very effective. And they talk a little bit about the literature around immediate postpartum implantation or insertion. And they find that the expulsion rate, they quote, is 1 to 14% by 6 to 12 months for the copper, which just, by the by, is a huge range, 1 to 14%, which is going to become an issue later on in the paper.
Mm-hmm.
And then they state that there isn't really good evidence around the levonorgestrel IUD, but in the little study that's been done, it seems to be about 24%, which is much higher than even 14%, the upper end of the copper IUD.
Right. And I totally agree. I think overall, it's it describes the study and the background really well, but I kind of agree in the sense that maybe they could have touched a little bit more about what the relevance of the study is, and maybe how the importance of this question that they're answering may impact, and I guess a little bit more than just, we're just comparing two IUDs. Because I do agree that there's a little bit more relevance than just the Iud insertion, which they kind of touch upon, but I don't think they go in depth in the introduction.
Yeah, and maybe they assume that the audience already knows that information, which I probably wouldn't assume. But in any case, that's one little quibble. They do go on to say that the reason they're even looking at this levonorgestrel is because it's become so popular. They state, and this we talked about in the contraception series I did, but 2% of people looking for contraception chose an IUD in 2002, and now it's 10%.
Right.
And that was 2012, so I'm sure it's even higher now. So it really is becoming very popular. And of those, most of those women are having the levonorgestrel IUD placed. So it's becoming so popular that they say, okay, well, we know this data about copper, but what does that mean for levonorgestrel?
Mm-hmm.
Should we use it the same way? Is it applicable to use it the same way?
Right. And I think they designed the study in a way that could answer that question pretty well, comparing those copper and the levonorgestrel kind of directly together.
Right. So I really agree that, their question, and actually why don't we do it right here? So they actually did what I love in their last sentence of the introduction. It tells us exactly what they're trying to do. So I'll quote it. We therefore aim to study if there's a true difference in expulsion rates between the levonorgestrel IUD and the copper IUD when all providers undergo standardized training and use of a standardized insertion technique. So right there, they tell you they're trying to see what the expulsion rate difference is between the two IUDs, and are they different at all. That makes the rest of the paper very clear, and we have, on this podcast, have done other papers where they don't do that, and I've criticized it, but I think here it tells you how important it is, because now I know the framework for how I'm going to interpret the rest of this paper.
Exactly.
All right, so how did they do this? Well, they designed a prospective cohort trial. It was conducted at those two hospitals in Colorado between May 2014 and August 2015, and their inclusion criteria were women who were already having a IUD placed. So right here, we're already getting into a little bit of selection bias. Right, these women have already chosen to do it, have already had it in, and then they are recruiting them after they've already had the IUD in.
Right.
Right, which is why it's a prospective cohort trial and not a randomized control trial.
Right. So later on, we'll talk about kind of some of the other things that they measure in terms of secondary objective. But if these are women who already chose to take the IUD, I think it'll kind of influence the patient's perspective on their satisfaction after having IUD, which we'll kind of talk about later on. Right.
Yeah. So definitely, I think for the primary outcome, it shouldn't matter. Right. Expulsion rate is kind of independent on whether the woman chooses to have one. Right. But certainly it does come into play in their secondaries. Like you said, we'll get there in a minute. So their exclusion criteria were pretty straightforward. They enrolled women who spoke English or Spanish, so that's pretty inclusive right there. They excluded women who were less than 18 years of age, and that's really for IRB purposes. It's difficult to enroll minors.
Right.
They excluded women who had multiple gestation. I'm assuming that is because the increased cavity from having multiples would make expulsion more likely. And then women who delivered less than 35 weeks gestation, which I'm not really sure why they chose that one.
Right.
But maybe, again, just for IRB, getting it through the IRB.
Right. Yeah, I think I do like the fact that they included both English and Spanish-speaking population, which I do think that kind of makes the demographic a little bit more broader, more applicable, especially to the bigger population.
Right. And again, we talk about this many times on the podcast here when we do Journal Club, but you're always in a push and pull between making your group narrow enough in order to be able to make conclusions, but broad enough to be generally applicable. And so I think they did a decent job here.
Right. I agree.
Yeah. So these women already had the IUDs put in. They went afterwards and they talked to them about the study and enrolled them after the IUD was inserted.
Yes. And then later, I guess, they had an abdominal ultrasound by physician between 24 and 48 hours to kind of document the distance in centimeters from the fundus.
Yeah, that's why this is actually going to be one of the more interesting parts of the study to me. And I love the fact, just spoiler here, but I love the fact it didn't work. Right? Because so often in medicine, we say, well, this should be correlated with this, and we should be able to tell. And then you go and you look at it and you say, oh, no, it doesn't actually work at all. And this is one of the nice things where, because that particular data point of the ultrasound was coupled nestled within this bigger study about expulsion rates, we got to know that negative answer.
Right.
Whereas if that study was done just with that ultrasound part of it, and that was the whole study, and it was a negative finding, we probably would never heard about it.
Right.
Because of the way that we publish medical research. So I'm very, very happy to see that negative finding here. If that part wasn't done, that would definitely have been a question that I would have wanted to ask. Is there any markers or any way to predict, depending on what a position is, immediate postpartum? And I think that kind of the fact that they mentioned it does definitely have to answer that question, and that a negative answer means, okay, that doesn't really, doing an ultrasound immediately doesn't really help to predict or see whether or not it's going to be expulsed. And I do think that was a really good add-on to the study. Yep. So then these women were then seen separate from their usual 6-week visit. They were seen at 6 and 12 weeks by the research team to do an exam, look for strings, do a transvaginal ultrasound, and also to do a satisfaction survey. So then talking about the actual IUD insertion, and they touched upon this a little bit in the introduction, that there are 2 different ways of putting in an IUD, immediate postpartum. So you can either put the IUD in a ring forceps and place it that way, or you can use the applicator that comes with the kit. Now, the investigators encourage all the providers to use the manufacturer inserts. There was lots of education, teaching. There was a training video available to watch. But what I found very interesting, and this comes in later into the results, but there's still a significant portion of people who chose to use the ring forceps.
Mm-hmm.
Right? And the providers basically said, we're not going to force anyone to do it some way they're not comfortable. But they did do their best to minimize that as much as possible. So it's like a little trade-off there. I would probably like to see if they just chose one way to do it and everyone did it that way. But I understand the reality of doing research is sometimes you can't make the perfect study. So I'm glad that they acknowledged that.
Yeah. And just personally having done it myself, for me, I think I prefer doing it manually, especially if there's like a lot of blood clots or something, and it's hard for me to kind of gauge where the fundus is. So the manual is definitely easier. But I do agree that that does add a little bit of variability in terms of, in terms of how it was placed may potentially affect maybe if the expulsion rate. But again, it's a little bit harder to control that, especially in the more dynamic setting,
right.
After delivery.
I mean, even regardless, the copper T and the Mirena, which is the one we use here in the U.S. mostly, they have completely different devices for insertion, and the copper T is not the easiest to use if you don't use it regularly, right? And so right there you have some bias anyway. So actually, maybe it would have been better if everyone did ring forceps. At least it all would have been the same, right? But in any case, again, that's a quibble. The overall study, like I said, I think is very well designed. All right, so the primary objective I already alluded to, but we'll go through it again. The primary objective was to compare the proportion of patients with an IUD expulsion, this is important, either complete or partial, by 12 weeks postpartum in either group. The secondary objectives included comparing complete expulsion, partial expulsion, unrecognized expulsion, IUD use, meaning were they still using it, satisfaction, complications, and then the last part was, can the physician detect a complete or partial expulsion just based on the history and physical alone? That part, a little tagged on for me, doesn't really fit the rest of it to me. Almost seemed like a different study, or maybe one of the people just had that question, so they added it on. And I'm not really sure that the study is going to be powered for that outcome, which we'll get into. So it seemed like a little tacked on to me, but that's fine.
Yeah, I thought a little bit kind of out of the scope of what they were, the study was designed to do. I didn't really think that was kind of relevant, to be honest. Right.
The definition, so for expulsion, they had a recognized versus unrecognized. Expulsion is pretty easy. It means the whole device came out. And then for a partial, they defined that as any part of the IUD below the internal os. And then for those women, they recommend that it be pulled and then and offered to be replaced. And we'll go through the outcomes for that in a minute. So they did they determined their sample size, when they just went around a 25% chance of expulsion of the levonorgestrel based on previous studies, and a 5% for the copper, and they were looking for a 20% difference. So they decided that they would need 50 people in each group with a 80% power and a alpha of 0.05. They decided to increase that by 10% to account for loss of follow-up, and ended up with 55 in each group. So that seems like it's well done, well calculated. Unfortunately, all their numbers end up being wrong, through no fault of their own. At the end of the day, the results don't actually change because of the direction both those errors were. But they're definitely there. It just goes to show you can design the best study, but when the rubber meets the road, that's when you find out what those real numbers are. But it was good.
Mm-hmm. I agree. I think it was overall, it was very clear the way they describe and kind of designed their study. It was simply done and they explained it pretty well how they did it.
Right. And especially that primary outcome being what it was, being a clear, measurable outcome with no ambiguity, really helps to make this study impactful. So we all have something, I think, to learn from that particular point there. So going into the results, they enrolled 123 women. 68 had received the levonorgestrel and 55 the copper. The demographics were reasonably similar between the two groups. The average ages were pretty similar. Relatively young, 26 and 27. The makeup of the race, again, relatively similar. They had about 55% to 65% Caucasian, about 30%, 15 to 30% African American, and then about 16% other, with about 65% in the copper group being Hispanic and 38% in the levonorgestrel being Hispanic. So that was one of the differences they saw, is a large difference in the ethnicity of the women choosing the different IUDs. This, again, may come into play what we were talking about here in New York State, where a lot of our Hispanic patients don't have access to care long term, and so they may choose to take that 10-year IUD over the 5-year.
Right. Yeah. That was kind of interesting for sure, with the Hispanic population choosing the copper IUD. It'd be interesting to see what their understanding of the IUD is. Why did they choose that one versus the levonorgestrel one? I don't think it necessarily impacts them necessarily, but the technical out-of-pocket cost for the copper IUD is less than the marine IUD. It shouldn't impact them necessarily, but I don't know if there's a component to their understanding of that as well, maybe.
Absolutely. The copper is definitely much cheaper than the levonorgestrel. The same things apply to gravity and parity, where women who had it was either the first pregnancy or their first delivery, were more likely to use the levonorgestrel. And again, I think this may tie into the Hispanic population here, where in general, at least in our population, our Hispanic women are more likely to be multiparous. And especially when they choose that levonorgestrel, they say, okay, I've had my 2 or 3 kids. I don't need any kids for the next 10 years. I'm done. Right. Whereas the 5-year levonorgestrel may be more attractive to someone who's 24, 25, just had one baby, and knows they want another one down the road. So I think that may play in there. Although again, it really shouldn't play into our expulsion too much, except in the fact that multiparous women, the uterus cavities are usually a little bigger, the uterus is a little bigger, so you would think maybe a higher expulsion rate or maybe a lower expulsion rate. I don't know. You can go both ways on the pathophysiology there. But that's only the only thing there in the demographics. Everything else was pretty much the same. Going into who placed the IUDs, actually, before I get to that, so 31% in both groups had used an IUD before. Right, so there seemed to be no difference in women who had already used an IUD, were comfortable with it. Again, I don't know if that goes to expulsion, but it definitely goes to satisfaction because they know what to expect already.
Right. The one thing in the chart that I kind of wish they had explained a little bit is the part where receive antibiotics for any reason under the delivery characteristics. Again, it could have been maybe for GBS prophylaxis, but it's unclear as to why they received it. And from my understanding, one of the contraindications to having a postplacental IUD is if you have a purple infection or potentially choreo. So I guess I kind of would have liked to see why they received antibiotics. Was it if it's GBS prophylaxis, then that's fine, but I don't think they really elaborate on that part necessarily.
Yeah, I can see. I mean, there's really should have been pretty simple to separate out why they received the antibiotics, because there really aren't that many reasons to get antibiotics in labor, right? There's GBS prophylaxis and then there's choreo. So it would have been nice. And although it's not statistically significant, again, the study wasn't designed for that outcome. And so it is 0.1, which is not that far from being significant. So, maybe that is, it could be an issue. Especially because more women in the levonorgestrel group had antibiotics. Right. So who put the IUDs in? Was there a difference? There was no difference. Most of them were put in by residents or midwives with a very small, I think 5% or less being placed by attending physicians. So there was no difference in the groups. So it wasn't like one group was more skilled than the others.
Right.
Although from my experience at my hospital, I would say that the residents are probably more experienced than the attendings anyway. So that probably is a good thing.
Yeah.
All but 7 of the IUDs were placed within 10 minutes, which is the recommendation for a postplacental IUD placement. And of the 6 remaining, they were placed within 17 minutes. So maybe they had a postpartum hemorrhage or extra bleeding, and then they got that under control and placed the IUD. Only 1 was after that, and that was pretty long after. It was 45 minutes.
Yeah, that one was a little bit, like, I was like a little questionable as to why it took the 45 minutes to put it in, but...
Right. And that goes back to, when you do a study like this, you design it, you try to control for all the things that you can think of. Invariably, you do the study, and then you say, oh man, I should have excluded that, or I should have controlled for that. And I bet if they went back, they would probably exclude any that were placed over 10 minutes or 20 minutes, whatever their cutoff is.
Right.
Again, just to get that homogeneity in their population, so you're not getting these outliers who are skewing your data. So I bet they would have control for that if they could do it again. But anyway, 27 were lost to follow-up, and they were pretty evenly split between the 2 groups.
Mm-hmm.
Again, this is a much higher percentage of lost to follow-up than they had anticipated, so about 22% as opposed to 10%.
10%, right.
They don't really talk about how they lost those patients to follow-up. Maybe they don't know.
Mm-hmm.
But that's a lot of women, and it's a relatively small study. To lose 22% of your women to follow-up is pretty huge. So in any case, that is going to skew our data a little bit, because now we have less of a population than we need to for the numbers that they were trying to get.
Right.
However, now we can get into the expulsion rates. They had a much higher expulsion rate than they anticipated. And so overall, with the rate being as high as it is and the difference being as high as it is, I believe they still can say they have significance even with the decreased numbers.
Right.
So let's go through those numbers. So 38.2% of those receiving levonorgestrel had a complete or partial expulsion, with 19.5% of the copper IUDs. So that's huge. First of all, they are combining partial and complete. So let's break it down to complete. The levonorgestrel had 27.3 versus 9.8 for the copper. Now, they assumed 5%.
Mm-hmm.
The rate they quoted in the introduction was between 1 and 14%, so 10% fits inside that.
Right.
And then their 25% is what they had assumed for levonorgestrel, and they had 27.3%, and that's for complete. I believe in their study sample size, they were talking about complete and partial. So in any case, much higher than they had assumed.
Right.
Perhaps just by the way they did definition.
Right.
Interestingly, the partial was pretty much the same between the 2 groups.
Right.
There's no difference. So really all the difference in expulsion rate was in that complete expulsion.
And it's also that the complete expulsion is still higher than the prior study that mentioned that the expulsion rate of 24%. It's close, but still, I do see that in this particular study, the expulsion rate is higher than what prior studies have shown for the levonorgestrel IUD.
Right. And then if they include those people that they lost follow-up, so that they still had some data on them, that would have gone to 35% for the levonorgestrel and 16.7% for the copper, which is still much higher. And so you have to ask yourself, is the definition different than the other studies? Are they doing something different? Maybe that doing the device insertion that comes with the IUD, maybe that is actually worse. Maybe putting it in with a ring forceps is actually better.
Right.
And of course, they weren't powered to see that difference in this particular study.
Right. But they do mention it. They do mention that their expulsion rate was higher than some of the other prior studies, but I don't think they really expand upon that too much.
Right. All right. So moving on, they now look at the ultrasound at 24 to 48 hours. And what they do then in the ultrasound is they measure from the top of the echo complex to the top of the IUD. And then they found that there was no association between that distance and the actual expulsion rate. They found that there was no difference in how it was placed or when it was placed, although again, when we start getting into those numbers, we're talking pretty small, because I believe there were only 10 women in the levonorgestrel and 5 in the IUD who had it placed with a ring forceps.
Yes. Yep. Mm-hmm.
Right? So, you were talking small numbers, so I'm not sure how much stock I'd put in that.
Right.
Then they did a couple of regressions to control for the parity, gravidity, and ethnicity, with the 3 things they found were different in the demographics. And when controlling for those 3 things, they found that truly the only difference was the type of IUD that was placed.
Yeah, so I think that the comparisons that they made in the discussion part, they actually do a good job of breaking down, what they looked at, and it does show that they try to consider all the possible, factors that may potentially affect the expulsion rate, and made it very clear that what it comes down to is the IUD type.
Yeah. So we're going to get back to that in just a second. Then just finish up our results here. So they looked at satisfaction. Satisfaction rates were really good. 76.8% rated it a 10 out of 10. That's how satisfied they were. And 92.7% rated it as greater than 8.
Mm-hmm.
I love that that the women who were happy, the majority did not experience an expulsion. However, 3 women who had an expulsion still rated it a 10.
Mm-hmm. Right. Yeah.
So the expulsion doesn't seem to have too much of an effect on their satisfaction.
Right.
Which is good.
Which is good. And I'm glad that they, it's in some ways kind of obvious that, of course, the ones who did not experience an expulsion would like the IUD. And this part also kind of goes back to what we mentioned earlier in a sense that these are patients who had opted, like they are the ones who chose to put the IUD in. So they're already kind of potentially had the research, may have potentially tried other contraception and thought the IUD is better. So they chose to do the IUD. So that may definitely color their response and their, especially if they didn't get expulsed, how they feel about the IUD in general.
Fair enough. So in women who self-select for an IUD, they're very happy, regardless of whether it gets expelled or not.
Potentially. That's a conclusion that I made.
Right. Okay. Fair enough. And then the last thing is they did look at the providers and whether they were able to detect expulsion. This is not going to blow anyone's mind away here, but they were able to detect complete expulsion relatively well. They didn't see strings, so they assumed it wasn't there. They did an ultrasound, confirmed, not there. Again, there's only 3 women, I think, that were in that group.
Yeah.
And then for the partial expulsion, they were pretty much terrible at it. Which, again, not surprising, because you see strings. Right? Now, unless you can see the IUD actually coming out of the external os, then you don't know it's partial, you just see strings.
Yeah, so, and that result wasn't anything surprising. I agree.
Right, so... Again, I'm not really sure why they decided to include that. I guess it is slightly interesting, but doesn't really feel like it fits. But in any case, so we're moving quite along. So let's move on a little bit further to their comment. They do a pretty decent job of going through what they think the biases could be. They actually spend not very much time talking at all about why maybe there's a difference. Right? I think it's only about a paragraph.
Yeah.
Right. But overall, I mean, they kind of recap their introduction a little bit. They talk about their results again, and then they go through, the issues being with self-selection, the issues with the way it was inserted, right? And then they talk about their secondary hypothesis a little bit. And again, they don't really say anything too much. But to get into their expulsion rate, or why there's a higher expulsion rate with the levonorgestrel, the 3 things that they think of that would be a string length, because the length of the string on the levonorgestrel is much longer than the one of the Paragard. Although they do quote a paper that says another paper did a similar study, but cut the strings on the levonorgestrel to be the same length as the copper, and didn't really see any difference in expulsion rates. So it's still higher for the levonorgestrel.
Right.
So that may not be it. Then they talk about the shape of the IUD, and they are slightly different, right? The copper really looks like a T. It's a straight T.
Yep.
Whereas the levonorgestrel kind of has little flanges on the sides that point down towards the cervix.
Yes, a little bit more curved.
Correct. And I mean, my personal experience, having put a lot of both of them in, the levonorgestrel IUD is a little more flexible than the copper IUD. So it's possible that it doesn't just withstand the contraction of the uterus postpartum as well as the copper.
Right.
That's going to be a difficult hypothesis to test.
Right. Exactly.
But to me, if it's something, it's probably that. And then the last thing they put up is the actual fact that the levonorgestrel has progesterone in it, and maybe that it has some effect on the endometrium in the postpartum setting that allows it to be expelled easier. Maybe it's not as sticky. Maybe you can't grip into that endometrium as well.
Right. Which I guess maybe. But again, that's hard to, I think, have a study to test that necessarily, I think.
Well, actually, it's going to be near impossible, right? Because the whole difference between the IUDs is that one has progesterone and one doesn't.
Right, so you can't really. Right.
It's hard to control for that.
Right.
You definitely could control for the size and the shape of it and the flexibility of it.
Right.
That means the manufacturer would have to manufacture a levonorgestrel IUD that has the same rigidity as the copper, which is probably not going to happen. But it is at least technically possible to imagine that study. Then they go into their, like I said, some of the limitations. They talk about the fact that they had a higher loss of follow-up than they would have liked. And they talk about bias. And they talk about the lack of standardization of the insertion, which also could be an issue. And then the last thing, the last paragraph, they try to get into, they're trying to frame their study now. Why is my study important and why should we listen to it? Why is even studying postpartum insertion good at all? Right, and this is actually something I wish they would have put in the introduction.
Exactly, yep.
Right, I think that they at least had to allude to this introduction to set up this last paragraph, but regardless, when I was reading this and when I've heard about this in the past, I have a public health mindset in general. Right, I mean, we talked about this on different podcasts, Dr. Ballas and I at least. And so when I see this, I say, okay, so if we have a 25% expulsion rate and it costs X number of dollars for each one of these, how much money are we losing there? But then how much money are we gaining by preventing an undesired childbirth? Right? And all the ramifications of that pregnancy. And thankfully, very smart people have already done this for us.
Mm-hmm.
And they have determined that at 6 weeks, you'd have to have an expulsion rate greater than 50%, 56%, in order to make it not worth, monetarily, not worth putting the IUD in.
Mm-hmm.
Right? I think that's great. I like, it's easy for humans to boil things down to money because you can measure those things.
Right.
I think that we have to then put on top of that, what does it do to the women who get pregnant?
Right.
Right. If we don't offer this.
Right.
And that's obviously very hard to quantify. I talk about this a little bit in the contraception series about the effects of undesired pregnancy and childbirth. But they're huge. They are financial, but there's also more to it than that. So if it's already at a 56% expulsion rate you would need, and we know we're already at least a 25 or a 20%, then this seems like a no-brainer to me.
I agree.
Man.
Yeah, I think
I haven't thought about this. Go ahead.
I was going to say, I think it was that really put this study in a more, I guess, on a level of this is really relevant, and I think kind of summed it up well. And I think when I was reading it, I was really happy that they included that last paragraph, because I think it makes, I guess, the question as to why they're even asking this question relevant more, and seeing that it is definitely cost effective. I think more people would kind of consider putting postplacental IUDs, and it's not just a matter of is it copper versus the levonorgestrel. Just postplacental IUDs in general is a cost effective if you think about it.
Yeah, again, this is a topic that I'd heard a little bit about. We do have one of our attendings at Stony Brook, Melissa Strafford, is involved in doing this, and she's involved with the Ryan Fellowship.
Yep.
And so I've heard about it, but I haven't really put too much thought to it, and seeing this really opened my eyes to say this is something that not only can we do, but we should be doing a lot more of. And even just from a public health point of view, even from an insurance or monetary point of view, if we prevent a few unwanted pregnancies and all the costs that go along with this, we have paid for the entire program.
Mm-hmm. Right.
So I think I'm going to take this and say, how can I do more of this? And even, as listeners know, I'm in private practice now, which is not usually, you would think, the prime area for this kind of technique. But there are plenty of women who end up with an IUD afterwards. Now, granted, my patients usually show up for their postpartum visit.
Right.
But still, why can't I offer this?
Yeah.
Maybe I should be.
Right.
And of course, in order to do that, and anyone who's listening who has tried to do this knows what the limitations are or the obstacles. But you have to get the insurance company approved before they deliver. You have to actually have the IUDs on labor and delivery.
Yes.
You have to have a labor and delivery staff that is receptive to you doing this.
Mm-hmm.
And of course, you have to have education for your patients to let them know it's available, what the expulsion rate is, so that if it gets expelled, they're not upset.
Right.
And then some way of getting them a new IUD if it does get expelled.
Right. I agree. Yeah, even having done it, I think I've done it only a couple of times here too, although I've seen it more. It's a hassle to kind of get the IUD available, have the patients get approved. And sometimes at least at our institution, the Paragard IUD is only available in a specific office during the day office hours. So if this happens, unless you plan ahead and definitely during the day someone gets it, during the night you might not be able to go get it. So it has to be a little bit more well-coordinated effort, which, doesn't always happen, or it's difficult to definitely plan out.
Yep, exactly. And I've seen at least in the Green Journal, I've seen a couple of papers over the years where people publish their experience implementing a program like this and all the things they learned and the process and the checklists and the obstacles that they overcame and how they overcame them. And I'd be interested, and maybe it exists, I haven't looked, but I'd be interested in having that kind of roadmap for implementing something like this. So you're not trying to reinvent the entire wheel in your own hospital, because every hospital is different. They have their own obstacles, but majority of the obstacles are going to be similar.
Similar, right?
So it'd be nice to be able to draw from other people's experience. So if any of you listeners actually have seen that, or you know it exists, please send an email in so I can share it with everyone else.
Mm-hmm.
So to sum up the paper, again, very well done, I think. They showed that there is a higher expulsion rate with the levonorgestrel versus the copper, even when controlling for all the other factors. They found that doing an ultrasound at 24 to 40 hours really didn't help predict who was going to have an expulsion and who wasn't, so it's probably not very clinically useful. And that in this self-selected group of women who wanted an IUD immediately postpartum, the satisfaction rates are pretty high.
Mm-hmm. Yeah.
Okay. So I like it when we get to listen, do a good paper. Next time I'll choose a bad paper,
okay.
And we can have a different experience. But it's nice every once in a while to go through a very well done one. So thank you very much, Dr. Kim, for your time today.
Thank you for having me.
And I hope you all look forward. Next episode should be the conclusion to PCOS, and then I have a very, very special October plan for all of you, so you can get excited for that. And again, thank you all for helping us celebrate 1 year of the OBGYN podcast. All right. Thank you all. Have a good week. We'll see you soon.
Have a good week.